My second question is about the donor selection. I think the myelofibrosis is one of the diseases where the haploidentical results are lower than the other ones, and I would like to learn your opinion about it.
Thank you. That is actually a very important question. Haplo results are really poor in with the post-SI approach. The results are really bad for myelofibrosis. As far as I know, only 4 or 5 of those transplants have been done, and they have not gone well. So we have done one. Dr. Bashi in Atlanta has done one. A couple of other people have done. You've done one. Did that go well?
It's not going well.
So
It's an ongoing battle.
Yes, so those the results with post-SI are not so good. In Italy, they have done with their approach with the high dose, high CD34 selected dose, and they claim they have done okay. But again.
Okay.
23-25% graft failure is a big number, and I'm just curious whether those graft failures are related to the amount of stem cells that are being infused during the transplant. So because of myelofibrosis, you can imagine that the bone marrow is really not a good niche for the stem cells to tackle in and then settle down.
Right.
Maybe some of the stem cells cannot anchor themselves into the bone marrow, and they're just sort of floating in the circulation and being destructed by some sort of apoptosis at the end. And I'm not sure whether if you can overcome this barrier by giving more stem cells and reducing the graft failure.
You're right. So actually, that's a very good thought. I've always thought that we should give like highest number of possible stem cells. We've not been able to get it because of the unrelateds. You have no control over where they stop. But when we have control, we usually try to give 8 million or more. But again, that's a soft sign. It's a combination of events. The important thing is the 23% graft failure rate is from before in the pre-Jakafi era. Those 2 studies were done just as Jakafi was getting approved. So most of those patients, actually none of those patients got Jakafi. I think the engraftment failure rate is going down with Jakafi. That's pure personal observation because of the better cytokine profile, shrunken spleens, etc.
Thank you. The second speech is about haploidentical transplantation in lymphoma.
Thank you. So I'll try to be quick with this one. This is a very provocative topic. Actually, if you went to EBMT, my colleague Dr. Hamdani gave this talk there. And this is data that we have generated from the CIBMTR and at our institution. So the thing is, why do we do allotransplant for lymphoma? So most patients who get allotransplants for lymphoma get it for auto failure or highly refractory, chemotherapy refractory lymphoma. And we looked at our own experience and the experience from the CIBMTR, and there is very provocative that we think haploidentical donor may be a better donor than even a sibling donor for these patients. And this may be because with the post-SI approach. So let's look at these data. So there's a lot of transplants being done for lymphoma. So in fact, the unrelated donor and activity for lymphoma is going up very steadily. If Chris might remember, in the 1999 or 2000, we looked at allo for lymphoma, and basically nobody was alive. After auto failure, people who got allo. That situation has now changed, and we have a lot more people getting allos for lymphoma. So the optimal salvage in patients who have relapsed diffuse large B-cell, there were 2 studies, the Canadian study and the Coral study. The Coral study's question was which is the better salvage option, ICE or DHAP with Rituxan, and turned out to be the same. But if you look at the Coral study, the majority of failures were people who couldn't even get to an auto transplant because ICE and DHAP did not work for them. So those are the people who relapsed while on this. Same thing with the GDP versus DHAP study done in Canada. So if you look at progression-free survival, the rapid drop is for the first few months where people actually did not respond to their salvage therapy. If you relapse within 12 months of your initial diagnosis, as you all know in the Coral study, and so if you had prior Rituxan, for example, and then relapsed within 12 months after diagnosis, their survival distribution was this way. For people who did not see Rituxan, if you had a Rituxan containing initial therapy and then you relapsed within 12 months, your prognosis was very poor. Relapse after 12 months was a little bit better. Again, prior exposure to rituximab and then failing was actually a worse thing. This is CIBMTR data for people who have early R-CHOP failure. So if you late failure, you do well, early failure, you do poorly. So early failure patients may be a group of patients where we need to think about allotransplant. People who relapse after R-CHOP in a very short period are going to be in this curve. So they give you a short time window to think about an allotransplant. That's the time window that we're talking about. Again, if you look at patients who have chemo-responsive disease and then end up having a allotransplant, the long-term survival is about 25%. If you look at chemo-unresponsive patients, it's only a touch better, less. So we still have. It was about, like I said, told you, when we first looked at this in the CIBMTR in 2000, and it was published in Blood at that time by Cesar Freitas, first author, 5-year survival was as close to 0 as you can get. There were literally no patients who are 5 years out. Now we have 5-year survival about 25%. So that's the best data we have for allotransplants in bad disease. This is overall survival for allotransplant for diffuse large B-cell lymphoma, and again, colleagues published this last year. So we identified some of the prognostic factors. If you have poor KPS below 80, you get 4 points. If you're chemo resistant, you get 5 points. And if you have an auto failure and you go from auto to allo less than a year, you get 2 points. And based on this scoring system, if you have 0 points, you actually have a pretty decent 5-year survival, about 40%. Now our competition for these patients is now going to be CAR T cells, because these are the patients who are getting, hopefully will be approved for CAR T cell therapy in the future, within the next year or so in the US. If you have very high with 10 or 11 points, you're essentially again down to about 10% survival for 5 years. So basically, poor performance status, chemo-resistant disease, and a short interval for auto failure are the 3 worst things, of which the most important obviously is chemo-resistance still. So the disruptive technology for this is CD19 CAR T cells, and this is the name for the first CAR T cell project that might get approved. They call it AXI-cell. It has a very long name, and this is going to be the commercial name. It's CD19 CAR. The overall response rate for CAR T cells in the same population, people who have primary refractory disease or people who have relapsed after R-CHOP within 12 months and not responding to salvage, is about 78%, 50% CR rates at 3 months, and that keeps on going down as you go further. So many of these patients actually may get CAR T cells and then come to us for allotransplant, because I don't think all of these patients are going to be cured with CAR T cells. Here is the allo data for Hodgkin's. Again, long-term survival for Hodgkin's allo is about 30%. So this is, of all the patients that we transplant with allotransplant, lymphoma seems to be the one group where our long-term outcomes are not good at all. And again, the reason why we started looking at haploidentical is the relatively low probability of getting a matched donor in the US for minorities. So patients, white Europeans have a 95% chance of getting at least a 1 antigen mismatch transplant. Same thing for African Americans, it's only 75%. So these are the alternative options that we are going to not spend time about this. We'll focus on haplos. So here is cord blood data, again, through the CIBMTR. So unrelated donors versus cord blood and unrelated 1 antigen mismatch donors. It's about exactly identical results for long term. Non-relapse mortality for 1 antigen mismatch is higher. Cord and unrelated 8 out of 8 close. These are very close results. So the cord blood is comparable outcomes to mismatched unrelateds and MUDs, matched unrelateds. But haplo, here we comes. There are 2 platforms. Obviously, we don't CD34 selected grafts with high intensity conditioning. That's the Italian approach. ATG approached in Asia, and we talked about this last year. But this is the approach that United States has pursued. Basically, a reduced intensity flu-cy conditioning, 2 grade TBI, bone marrow, and increasingly PB in some of these 2 doses of post-cytoxin and GCSF, MMF, tacrolimus. So the alternatives are T depletion with megadose CD34, that's the Italian approach, and this is the Beijing protocol, which over time has evolved like this. Post-Cy, again, everyone knows the rationale for using Post-Cy. So you get this alloreactive T cell proliferation, which many people have tried to utilize because the haploidentical product can see T cells. The T cells in the haploidentical product can see that it is in a mismatched body, undergo rapid proliferation. Many people get cytokine release syndrome type reactions with this, especially if you use a PBSE graft, because that has a much higher T cell burden. And then the reaction subsides when you give Post-Cy, and alloreactive T cells are killed, whereas the non-proliferating, non-alloreactive CD34 cells are spared. So this is the Hopkins data again that you know all about. So we do. The haplo is the most rapidly growing part of transplant, not just in the US, all over the world. So we had a BMT-CTN study where there was a haplo versus cord comparison. So people who are not in that study are the people who are actually taking it off. And in this same thing in EBMT, as you can see, cord blood and haploidentical transplant, cords going down, haplos going up, and this is the year when haplo-cord paper was published. The haplo versus cord comparison paper was published. So we published this in Blood, where we tried reduced intensity approach for lymphoma, haplo versus unrelated donors. So 900 lymphoma patients between 2008 and 2013. MUD with or without ATG versus haplo. And we only looked at reduced intensity conditioning, because similar study we did with reduced intensity transplants for haplo versus matched SIBs, again, about 1,000 lymphoma patients between 2008 and 2013, comparison of matched SIBs versus haplo, and again reduced intensity conditioning, because we wanted to have patients have the effect. We purely wanted to find out the effect of graft versus lymphoma in these patients, and not the effect of whatever conditioning they got. So here is the so here is the GVHD rates. So MUD without ATG and MUD with ATG are the blue and green lines, and haplo is this. So the acute GVHD rates, the cumulative incidence is about 15%. Chronic GVHD rates are exceptionally low for haplo, as you all know, in the Post-Cy approach. This was restricted to the Post-Cy haplos. MUD without ATG has the highest, obviously. With ATG, you can reduce it by almost 20 points, chronic GVHD rates. And as you can see, about 40, 60, and 15% chronic GVHD. Non-relapse mortality, very similar, 11, 30, and 20, but the lowest non-relapse mortality is for haplo at 1 year and 3 years, 17% at 3 years versus 26% unrelated donor with ATG. Relapse rates, 30% for haplo, 22, 27 at 1 year, 36% at 3 years for haplo, and 28 and 36% at unrelated donors. So if you look at progression-free survival and overall survival, haploidentical is right in the middle, 76% 1 year overall survival with 78 and 65 for this, and 60% 3 year overall survival, whereas unrelated donor with ATG is 50%. So we have, this is a large number of patients and unselected except for reporting to the registry. And remember, this is the early days of haplo in the US. So this is for match-related donors, 1,000 lymphoma patient between 2008 and 2013 again. GVHD rates identical, 8% acute GVHD, and chronic GVHD, again, significantly lower for haplo versus match-related donors. Haplo Post-Cy is especially effective in reducing chronic GVHD. Non-relapse mortality, again identical, 10%, whereas relapse, exactly identical, 30%, and at 3 years, 37 and 40. Progression-free survival, identical at 1 year, 60%, 3 years, identical, 48%. Overall survival, 60% at 3 years. So this is probably the best data that we have for allotransplant in lymphoma compared to all the other historical data that we have generated. So we then looked at EBMT. This is not a study. We just asked them if they had similar data, because we are so excited that we proposed this to various people, and still there is a lot of skepticism accepting this data in the US. But again, you can see that haplo-post-sci versus sibling, mud, cord blood, everything. Haplo-post-sci is remission rates and type of lymphomas. This is split by type of lymphoma. This is the EBMT data. Haplo-post-sci, non-relapse mortality is a little bit higher in them. This is haplo others, this is haplo-post-sci. So because in EBMT they have both types of haplos in there. So here is the Italian turns out to be the highest non-relapse mortality, at least for lymphoma, and overall survival to the Italian version. So if you're going to do a haplo, there is no doubt that post-sci is the way to go. And here again, this is only about 20 months, and this part of the curve is probably unstable. But as you can see, this is just as good as everything else. So the limitations are that, there is a package effect with haplo. So it's not haplo, it is the post-sci approach which is the problem, which is the thing. So the question really is, should we be doing every donor with post-sci? You can reduce the risk of chronic GVHD, you can reduce the risk of TRM, because that's how the haplo won out. So why we could do a PB graft with instead of doing it with CNI based GVHD prophylaxis, you can do a calcineurin free with post-sci approach. And would alloreactivity from day 0 to 3 be better for mismatched grafts, or choose, so there's actually provocative data coming that in the setting of post-sci, it doesn't matter whether you're 1 antigen mismatched, 2 antigen mismatched, or up to 4 antigens mismatched. So actually there's an ongoing study through the BMT or RCIBMT where we are doing up to 4 antigen mismatched unrelated donors with post-sci, and we actually are choosing donors who have greater disparity to see what happens. So it's very provocative. I wanted to present this here. Actually, I requested Dr. Beksach to let me do this data, because I think this is very provocative data that the best donor might be a post-sci graft, irrespective of the amount of mismatch. Because this is the only setting in which a haplo graft has been shown to be equivalent, only disease in which it's been shown to be equivalent, because everything else we look at, relapse rates tend to overpower the benefits of GVHD and non-relapse mortality. Obviously, there's some issues with power, short follow-up, retrospective data, but the number of patients is very impressive. It's almost 1,000 patients in each group. Similar thing with...
Go back with the stem cell source? This one.
Yeah. Oh, this is a chronic GVHD rates. It's definitely higher with PB grafts. But again, PB grafts tend to give you the bigger effect of GVL.
But this isn't lymphoma.
This is not lymphoma. This is all comers for haplo. Yeah, this is not lymphoma. So there's one disease where haplo seems to be better than matched sibling donors, which is Hodgkin lymphoma. So again, similar data that we've looked at the CIBMTR, 3-year overall survival for Hodgkin lymphoma patients these days getting a haplo transplant, 71% versus 60%. And it's definitely very encouraging in this disease. So here is data for the impact of donor type in 1-year mortality after transplant, 2012 to 2014. So match related, unrelated, 6 out of 6 cord bloods, 7 out of 8 unrelated, and haplo are in this group, and mismatched cords are in group. So haplo, this is again all diseases, not but if there's one disease that stands out from the rest of it, it's lymphoma of all types, Hodgkin's and non-Hodgkin's, because the majority of these patients are diffuse large B cell with chemo-resistant disease. Some of the other caveats, Chris already talked about clonal hematopoiesis of undetermined significance or CHIP or the problem is, when you do haplos, a lot of the times you end up choosing the patient's siblings, and older patients with lymphoma, you end up choosing the siblings who are also equally of older age, and you end up getting worrying about donor-derived malignancy. We've actually had myeloma transplanted to a donor. We had an AML patient who had lymphoma transplanted into the AML patient. So the patient's donor had follicular lymphoma. The patient themselves, after AML, developed aggressive diffuse large B-cell lymphoma from the donor. So, the patient, again, MGUS person, donor, myeloma after 6 months in the recipient. So some people have looked at this, but again, this is something that we have to think about. So if post-SI approach is the difference, maybe why don't we choose young mismatched, the youngest possible mismatched matched unrelated donor, use post-SI. So these are all very provocative questions, and these are questions that, again, you might be able to answer in Turkey itself if you do a study, because this post-SI transplants are so easy to do. I think the reason why I wanted to present this is if you're going to choose one disease to compete with other donors or do post-SI as your platform, lymphoma should be that disease. Because we have shown it in Hodgkin's, non-Hodgkin's, and with both unrelateds and siblings.
Thank you, Dr. Hari. Thank you. Are there any questions? Yes, Jörgen, and you. Just 2 questions, please.
Well,
Sorry.
that's very nice. And in that CIBMTR study, did you guys actually look at those patients who had bad lymphoma versus good lymphoma to see whether those results are really sort of overlapping?
Yeah, actually, so we put everything in one group, and in the multivariate, actually the type of lymphoma it was not interacting with the type of donor. So actually, we did do a multivariate analysis. I just wanted to show you the high-level results. But
chemo-resistant lymphoma,
essentially chemo-resistant lymphoma was the highest proportion in those 2 papers, and that's. Chemo resistance did not matter. It was poor for outcomes, but the donor type did not interact with the chemo resistance.
Okay.
So it was not superior in chemo resistant.
But the other thing that we need to really be cautious about these data is haplotransplant, the median follow-ups are really not the same.
Absolutely.
And if you follow those patients in the long term, you might be able to see the curves actually separating. And I think, maybe I'm not right on this, but I think you're just kind of wiping out the T cells. That's why you don't see GVHD. That's why you don't see anything. You're just like doing